The session title is Breastfeeding Interventions, Navigating Ethical Challenges to Ensure Equity Using the Public Health Ethics Framework. And maybe some of us are asking, why are we talking about breastfeeding at this time? We are going to run these sessions two ways. It's going to have a session whereby we are going to have presentations from our experts. We are also going to have a session of the workshop to really address the skills about navigating the ethical challenges to ensure equity using the public health ethics framework. I want to introduce our panelists that are going to help us navigate this title. This session, I'm going to co-chair with Professor Muhuthia, and I'll invite Professor to come here. Professor Muhuthia is a pediatrician. He's based at the Nairobi Hospital. Sorry, Prof. He's also the co-director of Africa Bioethics Initiatives. Welcome, Prof. He is going to take the second part of the session in terms of leading the bioethics component. Our guest speaker, we have Dr. Edgar Kalimba. Dr. Edgar Kalimba wears many hats. He's the Deputy CEO of King Faisal Hospital in Rwanda. King Faisal Hospital actually is the largest referral hospital in Rwanda. He's a pediatrician, pulmonologist, he's a researcher, so we are going to learn a lot from him. We are really honored to have him take the first seat in speaking to us today. We have Bishar Osman Hussein. Bishar Osman Hussein is a health and nutrition program coordinator in Concern Worldwide in Somalia. They are dealing with vulnerable populations. Bishar brings a wealth of experience in working with vulnerable populations in promoting breastfeeding. We have Ms. Veronica Kirogo. Ms. Veronica Kirogo, she's the Director of Nutrition and Dietetic Services, Ministry of Health Headquarters in Kenya. She brings a wealth of experience, having worked previously in agriculture, then in health. So she's going to share with us her experience. Finally, we have Professor Nicola Villa Adrona. She is the Director, Institute of Biomedical Ethics and History of Medicine, University of Zurich, which is a collaborative center of WHO in bioethics. She will be speaking to us virtually. So colleagues, I invite you to this session that I said the title is Breastfeeding Interventions, Navigating Ethical Challenges to Ensure Equity Using the Public Health Ethics Framework. Throughout this conference, we have been talking about primary healthcare. Primary healthcare is about the first healthcare that actually starts in the household. So when we think about breastfeeding, where does it start? When we think about ethics, where does it start? So I want to invite Dr. Edgar Kalimba to talk to us about the importance of breastfeeding from a global perspective. And he will also tell us how they have integrated breastfeeding into primary healthcare in Rwanda. Welcome, Dr. Kalimba. You can speak from there.
Thank you very much. Thank you very much, Dr. Lakati, for the introduction, and good afternoon, everyone. I would like to thank you for inviting me to this session. particularly to LactaHub and Amref International University for this important discussion this afternoon. I think the two questions that the audience have participated in have already highlighted that we are more or less on the same page. So when it's often said, and to a large extent, there's a lot of truth in it, that we are what we eat. I think in a way that's to say that nutrition has a huge impact, not just in health, but in well-being in general. And if there's one thing that really is holistic and optimal in terms of nutrition and health in general, would be breastfeeding. And so breastfeeding and breast milk is not just an ideal nutrition, but as we all agree in this room this afternoon, it's the best possible nutrition that actually promotes growth and development. And of course, what sets breastfeeding apart is that it's not just nutrition, but also very important in the sense that it promotes immune development and really helps infants and children to be healthier. And so it is this same reason why the WHO actually recommends the initiation of breastfeeding within the first hour of life, exclusive breastfeeding the first 6 months of life, and then of course continued breastfeeding up to 2 years. So as a pediatrician, of course, I'm also a very strong advocate, because we know that breastfeeding and breast milk plays a big role in reducing not just morbidity, but all-cause mortality. We often say that breastfeeding is critical to reduce lower respiratory tract infections, diarrheal diseases, but also in terms of small and vulnerable newborns as a modality that we know that the big burden of children who die before their 5th birthday, breast milk actually plays a huge role. And the benefits are lifelong. I think sometimes we don't remember that actually the benefits of breastfeeding and breast milk are lifelong, up to when we are adults. When colostrum, the first milk, and breast milk in general actually sets a human being down a path, a good inflammatory pathway. And that's why things like secretory immunoglobulin A, lactoferrin, lysozyme, and all these immunomodulators that are only found in breast milk play a critical role in the kind of health that we have even as adults. The other element, obviously, to highlight is that when we talk about breastfeeding and breast milk, what comes to our mind is the baby or the infant or the child. But the fact is that breastfeeding actually has tremendous benefits for the mother as well. At times, we look at the draining, exhausting part of a mother who's just had a baby, the nights, the cluster feeding, the exhaustion sometimes. But the fact is actually that mothers who nurse benefit a lot, not just in terms of postpartum recovery, physical health and recovery, but also in terms of psycho-emotional stability. So as an example, we know that postpartum depression, anxiety, concerns with body image are actually much less pronounced in mothers who nurse, who breastfeed, than those who don't. And so is bonding, which is a huge part of psycho-emotional development of a child. And these are just in the immediate term. In the long term, we know like things with regard to breast cancer, other types of cancers, osteoporosis. The list is long in terms of the benefits to the mother. So when you look at the global perspective, just very briefly, it's quite encouraging. You realize that in the past decade, actually, the rates of breastfeeding have increased globally. You know, there's this World Health Assembly target for 2025, which is exclusive breastfeeding of at least 50% in the first 6 months of life of the infant. And I think in the past decade, there's been actually good progress where we currently around 48% in 2023, according to UNICEF. So when you look at Africa, or if you look at the low and middle income countries, which obviously carry the highest burden of not just morbidity and mortality in children, you see a lot of variations. So for example, with regard to initiation of breastfeeding within the first hour of life, which has tremendous benefits, obviously, there's very few countries that are actually on track to achieve the levels that are recommended. Or if you look at exclusive breastfeeding as well. So there's a lot of variety. We have very few countries that are actually doing well. So there's a lot of work and a lot of opportunity for the policymakers in the room and for all of us who are contributors to this in one way or another. So what about Rwanda? Some of us in the room might know that, you know, the 1994 genocide against Tutsi in Rwanda was like a reset for the country. We really started from zero, from scratch in every aspect that you can imagine. And if you look at the trend that the country has taken and the achievements that have been achieved with very, very limited resources, it made sense, I think, as Alice mentioned about public health, there's been a lot of investment in primary health care. And that has gone a long way in taking us to achieve a lot of health measures in a relatively short time. But specifically looking at breastfeeding, we actually have one of the highest rates in the country. Obviously, Rwanda is a much smaller country compared to some of the African countries. We are a little bit obsessed with structure and, you know, accountability and multi-sectors working together. And so that has helped a lot. So we actually have around an 80% exclusive breastfeeding rate the first 6 months of life, which is not perfect, but quite good. And we even have a higher rate of early initiation. And of course, if you look at all our guidelines in Rwanda, if you look at the antenatal care guideline, if you look at the other guidelines, including the nutrition policy, breastfeeding is a core, it's a pillar in all these guidelines. And that has played a huge, huge role in a lot of the achievements that have been registered in our primary healthcare in general. So specifically, you might be aware that we work in a pyramid like many other countries. So we have tens of thousands of community health workers in Rwanda, because health care, in a way, is initiated within the community. So the community healthcare workers have a couple of households. They have a phone, a smartphone, and they have to monitor certain things and report to the health center. So, and this has played a big role in terms of mobilizing mothers in the course of pregnancy, educating them, making sure they make the 8 contacts that are recommended. But also when babies are born and they go back to the communities with their moms, particularly the vulnerable newborns, the small and vulnerable newborns that struggle with breastfeeding. So a lot of interventions, simple interventions, actually start within the community. So that has really been integrated and has played a big role. And of course, all these guidelines that we have and we use and we follow stress and put a focus on breastfeeding. And again, when you look at the health centers, more recently, we have introduced a couple of interventions, whether it's the supplements that the mothers take postpartum, you know, MMS, calcium supplements, food packs. All these are actually meant to help the mothers to keep up with breastfeeding, particularly the exclusive breastfeeding policy within the first 6 months. And then, of course, there's other things at the primary healthcare level that have worked very well in Rwanda. You know, I think most of us know that health insurance is actually a law in Rwanda. So up to 96% of our population, including the rural population, have to be affiliated to the community-based health insurance. So this has increased access to care. We have very high vaccination rates for infants. And these, coupled with a strong emphasis on breastfeeding, have undoubtedly played a big role at our primary healthcare level. So I think I will not take a lot of time. I will just cap it there, and back to you, Alice.
Wow. Thank you very much, Dr. Kalimba. I mean, I think he deserves an applause. We have a lot to learn from Rwanda, 80% exclusive breastfeeding. And I don't know why you put it a bit negative to say you are obsessed in Rwanda with structure and accountability. I think for us, that's really a very good thing that Rwanda is showing the world that it is possible to have guidelines, to have structure, and actually meet those targets. We have also seen that your community health workers have a smartphone that allows them to collect information and connect to health facilities. These are really great strides in primary healthcare. And I like what you say, that the good news is breastfeeding is increasing rates. But do you have maybe areas where breastfeeding is declining from? Do you want to say something about, are there areas where breastfeeding rates are declining?
Yes, particularly in the urban population. So our current official data, which is the demographic health survey for 2020, actually shows on average the urban population in terms of exclusive breastfeeding is much less compared to the national average, which is understandable. You know, lifestyle, the working environment. We only have maternity leave for 12 weeks. And so there's all these things that are challenges. But, you know, in the last couple of years, there's a drive in Rwanda to encourage working mothers to actually express. You don't have, you know, babies can still be breastfed or be breast milk fed even while their mothers are away. And there's all these, you know, things that have come up frequently. At my workplace, we have it. We have an ECD, Mothers Can Express. There's provision of fridges and rooms and facilities for mothers to actually express breast milk while they are even away from their babies. So there are challenges, but there's also a lot of opportunities that are being tapped into.
Thank you. We want now to move to Mr. Hussein. Mr. Hussein works with Worldwide Concern Somalia. Mr. Hussein, we'd like you to tell us about what is happening with the vulnerable populations in terms of primary healthcare, in terms of supporting breastfeeding. That is an initiative that we know saves lives.
Good afternoon, colleagues. It's my pleasure to talk about this topic. It's a topic that I am very passionate, a topic that I believe in, actually. And I look forward engaging many of you about this topic. So basically, next slide. Okay, why does it matter breastfeeding in vulnerable populations? This is the first question we ask ourselves. And Dr. Eric talked about the scientific background, but specifically, why does it matter in vulnerable populations? First, there are a number of scenarios, there are a number of factors surrounding to it. And if those factors are not addressed, they will always remain in a problem. Number one, we could look back the recent statistics. Only less than 50% mothers are able to breastfeed their children in the first 6 months globally. So you can imagine almost 50% are left behind. Particularly, those vulnerable are more susceptible. Second, we know the risk associated with lack of breastfeeding. So for those 50% missed the opportunity to timely breastfeed, they are highly risk for life-threatening diseases, malnutrition, low birth, and all those will compromise the potentiality of that child. Thirdly, the vulnerable groups, especially women and infant and marginalized community, are more susceptible if they don't breastfeed their children. It will make more deteriorated and more difficult, especially in the context where I come from and many African countries where the situation is very fragile and people are in a vulnerable situation. Lastly, Dr. Eric mentioned well how it affects the immune system and how it can potentially, lose and reduce the potentiality of that child. And also it can increase the risk of death as well. So these are the main drivers. Why do we need to talk about specifically the vulnerable groups in breastfeeding? One of the key issues is around the ethical challenges in implementing, breastfeeding interventions. Equity and access to breastfeeding support is an issue, and a standing issue. For example, there's quite significant healthcare disparities, especially rural and marginalized community. If this is not addressed, it will be a standing agenda, and it will be still keeping on to raise the rates. Social inequality is also one of the key factors surrounding intervention supporting breastfeeding. Commercial influence and WHO code of violations. In many countries, still this code has not been adopted, and commercial influence is very high. So still it's a threat. One of the things is that there's unethical marketing of breastfeeding substitutes across many African countries. Companies are aggressively marketing infant formulas in many countries in Africa. This is also undermining, the potentiality to guide proper breastfeeding. Culture norms is also one of the biggest factors. As you know, some social communities, they have some stigma giving breastfeeding to babies in public places. Mothers working in places where there's no possibility to get privacy, and there's a social stigma is also one of the impacts. Gender disparity in relation to decision-making power, male-dominated societies, decision-making in many communities, husbands, elders dictate infant feeding choices. So it's also one of the factors that is quite problem to proper breastfeeding. Workplace barriers, especially women in informal settings, low-wage employment, they also face that challenge. Humanitarian crisis and displacement is also another challenge hindering breastfeeding and breastfeeding practices. Some of the cultures, we talked about the ethics. We can mention a couple of points in relation to the beliefs and the cultures of the community. Number one, there are social norms and stigma around public breastfeeding in many societies. As I've mentioned earlier, breastfeeding in public is discouraged, perceived something in the community is not normal, forcing mothers to use alternative feeding bottles. Fear of judgmental may prevent mothers as well. In the other aspect, it's not moving. the gender roles and decision making. Fathers, mothers, community elders often have more influence over infant feedings and decision making than the mother. So it's also a quite challenge. Some communities expect women to resume work or household chores immediately after birth, limiting time for breastfeeding. The same things now Dr. Eric was talking about, the paternity leave and all that. Myths and misconceptions are among the rising topics for breastfeeding obstacles. Some of the, very important elements for breastfeeding is the first hour, where the child can receive the colostrum, and some cultures they discourage. It's also a big social issue. Next. What are the promoters for breastfeeding in vulnerable communities? Number one, policy and legal protections are one of the pillars that can promote interventions supporting breastfeeding interventions. Governments, donors should prioritize funding and supporting these initiatives. Strengthening laws and policies will also play a key role, especially adopting WHO guideline or code in the breast milk substitutes. Advocating for paid maternity leaves is also one of the elements we have talked about, how it's a challenging. Community and workplace support is a very important aspect, especially maternal leave, and also involving community leaders for these aspects. Equitable access to breastfeeding supports. There's a lot of health disparity we talked about. So one of the elements we can eliminate that is more of getting equitable access to breastfeeding supports, strengthening the healthcare systems. Ethical emergency response and resource allocation, response allocations is also very important element that can promote intervention supporting breastfeeding. Community and workplace support is very also one of the elements that can promote breastfeeding in vulnerable populations. How can we enhance the quality of breastfeeding support and protections? Given the context I have talked about, I think one of the things is to increase investment in breastfeeding programs, educating mothers, allowing them opportunities to breastfeed their kids as early as possible, strengthening family-friendly workplace policies is very important, implementing and monitor paid maternity leaves, expand access to avoidable and quality care to support working mothers, regulate and monitor the marketing of breast milk substitutes is also one of the things that can enhance the quality of breastfeeding and intervention support. What could be the takeaways? Although we will come to the end of the session, but in my presentation, what I thought could be the key takeaways. Number one, invest in breastfeeding, life-saving breastfeeding programs. Second, health system strengthening, because if the systems are not functional, we talked about health disparity, we talked about limited health services. So if we don't tackle that, that problem will still exist. So one of the key things is health system strengthening. Enforcing the International Code of Breast Milk is also a one key important aspect as a takeaway message. Ensure emergency preparedness for infant feedings is also another element that's very, very critical. Support maternal nutrition and well-being of the mothers is a very important and critical. In workplaces, especially informal workplaces, we don't have friendly spaces that lactating mothers are able to breastfeed. So it's a point to advocate in those places to create this supportive environment. And lastly is to scale up community-based breastfeeding support interventions, as well as we don't have any reliable data. It's important to monitor the data as well, so that we can determine the percentage and the rate of, breastfeeding. That's it. Thank you very much.
Thank you very much, Bishar, for educating us and really highlighting that in vulnerable settings, there is unregulated marketing of formulas. And I think the setting becomes more challenging. So we would like to, please take your seat. We would like now to come to bring ourselves closer to addressing the issue of the public health ethical framework. But before that, we want to hear from Ms. Veronica Kirogo, who is the Director of Nutrition and Dietetic Services. Ms. Veronica will tell us about the breastfeeding interventions and ethical challenges in breastfeeding research. Or take it up. Yeah.
Good afternoon. Yes, you can see that photo of that lovely nursing woman. So that's a trademark for us in all our materials in Kenya on breastfeeding. So I want to just share briefly on a Kenya experience. We can go to the next slide. And as the previous speakers have said, even Kenya, we recognize breastfeeding as a cornerstone to survival, child development and development. And therefore it is part and parcel of our primary health care and also at the community health system. And the other thing I also wanted to share is, according to our Kenya health policy, we have established that suboptimal breastfeeding is one of the leading causes of infant and child mortality and morbidity in Kenya. And therefore, as a government, we are really focusing on promoting breastfeeding so that we can improve the nutrition outcome. Of course, we are led by the various policies that we have, and we have very favorable policy environments for supporting breastfeeding. One of it is starting from the Kenya Constitution, 2010, which gives every child the right to basic nutrition. And as Alice was taking you through the Menti, when what came out is that when you mention about breastfeeding, you think about nutrition. So similarly, in our Kenya Constitution, giving the right to basic nutrition for all children, for infants and young children, breast milk becomes the basic nutrition. We also have various other policies. We have the Kenya Health Policy. It also has identified breastfeeding as an intervention toward reduction of morbidity and mortality. We have the National Food and Nutrition Security Policy 2012. This is a multi-sectoral policy, and it also has prioritized breastfeeding as a high-impact intervention. At the community level, we have the Community Health Policy, which also has put breastfeeding as a comprehensive intervention in the maternal, child, and health activities. But for us to be able to implement this policy direction, we have the national, what we call Kenya Nutrition Action Plan. And these are actions that bring into for the policy directions that are described in the various policies. It's also a multi-sectoral action plan, bringing together all the sectors that have a role in nutrition. Next, please. When I start here after Dr. Eric, I am feeling a bit challenged because Rwanda, they say they are at 80% exclusive breastfeeding. Kenya, we are struggling at 60%. That is according to our latest Kenya Demographic and Health Survey 2022, which was a reduction 1 percentage point from 2014. At 2014, it was 61% exclusive breastfeeding, reduced slightly 60%. We are doing a deep dive into what really went wrong in terms of that decrease. But nevertheless, when you look at the global nutrition target on exclusive breastfeeding, we are doing well because we are over 50%. But why should 40% of our children not benefit from this gold standard of nutrition? And that's what we are working in. For us to be able now to increase the coverage of exclusive breastfeeding, we have various key interventions that we are promoting, starting from maternal nutrition education. When the mothers are expectant, we take them through nutrition counseling. Then when they come to delivery at the health facility, we are implementing the baby-friendly hospital initiative, which is the 10 steps that we are guided by the WHO. And seeing that after the mothers are discharged to the community, they also require support. Another initiative we are implementing is baby-friendly community initiative. And this initiative empowers the community to support nursing mothers, protect and promote breastfeeding. And we have also in that platform, we establish what we call mother-to-mother support groups so that nursing mothers can be supported by their peer who have gone through the experience and be able to sustain breastfeeding. The other one is we are also doing breastfeeding mentorship. We tried this as a pilot in the last 2 years in one of the referral hospital we have. And this is mentoring health workers who are the first contact of the nursing mothers or pregnant mothers for them to be able to support the mothers to breastfeed. We are also having workplace support for breastfeeding. We have enacted a law that requires every employer to establish a lactation station for nursing employees. That is currently in force. And it's really for the companies or organizations that have those breastfeeding species, they are really improving in terms of helping the nursing employees to sustain breastfeeding. The other intervention is the human milk bank. We have one human milk bank at our largest maternity hospital in Nairobi, Pumwani Hospital. And this bank caters for especially the low birth weight and also the infants born in that hospital who maybe have lost their mothers or their mothers are not able to breastfeed, so they benefit from the milk in that human milk bank. We also, Kenya has about 47 counties. 23 counties are in the arid and semi-arid areas. And therefore, from time to time, we have emergencies. And you know what emergencies does to women who are lactating. And we have intervention that support them, especially during climate shocks, support them to be able to sustain breastfeeding by giving them food relief, also treating those who are acutely malnourished for them to be able to sustain breastfeeding. Lastly, the other intervention is advocacy, because for us to be able to promote, protect, and support breastfeeding, advocacy is key. And we have always been celebrating the World Breastfeeding Week every year to really advocate for that support. Like last year, we held it in one of our women prison in Nairobi, and we were able to experience the challenges that women who are in prison have in terms of sustaining breastfeeding. Next, please. I just wanted to share with you just key achievement, which breastfeeding is also a contributory, especially in the overall nutrition outcome. We have been able to reduce stunting from 26% in 2014 to 18% in 2022. And our target is to reduce it to below 15% by 2030. Similarly, under 5 mortality, infant mortality, and neonatal mortality, we have observed also quite some reduction. I had mentioned about the exclusive breastfeeding rates. And in terms of baby-friendly hospital initiative, we are sort of now rolling it out. So far, 125 health facilities are implementing the BFHI. At the community level, I mentioned about the baby-friendly community initiative. We have more than 800 community health units who are implementing that initiative. And we have 1 human milk bank, and we have over 100 companies and organizations who have established a lactation station at the workplace. Some of them even have gone beyond the provision of the Act and actually provided facilities that can work as a day, child day center for the employees with young children who are breastfeeding. Next, please. I won't dwell so much on this. I know Bashir mentioned, I think they are almost similar in terms of the ethical challenges in Kenya. But maybe what I wanted to say in terms of the social cultural barriers, one of the ethical concerns is how to respect the cultural belief, because we have many tribes. How do you respect that while promoting the evidence-based breastfeeding? So that's an ethical concern that we have. At the workplace, in addition to having that act that provides for the lactation station, of course, for the companies, especially profit-making, that dilemma of balancing the business productivity and also the rights for the nursing employee. But I wanted to share through this act, there are some companies. We have a company which is a tea plantation, and they were able to establish a lactation station, actually a daycare for the women who are nursing, and they are tea pickers. And one of the things that the manager shared when we went for the routine monitoring is that they have seen that the company has increased productivity, because now the women who have children who are nursing don't have to come every time saying, please give me an off, my child, I need to go and breastfeed, or my breast, are really paining because of the engorgement. So there's a lot, even as we are balancing that business productivity. Of course, conflict of interest. Kenya, we have the Breast Milk Substitute Act, which is the one that gave to effect the International Code of Marketing of Breast Milk Substitute. But of course, we continue to experience aggressive marketing of the breast milk substitute by the infant formula manufacturers. Right now, the biggest challenge is the digital marketing. 2 weeks ago, the challenge I was trying to address was an influencer in their social media was promoting some of the designated product under the BMS Act. So the issue of how do you counter the digital marketing also is just a key, a real dilemma. On equity and access, one of the things is that, ensuring equitable access to skilled breastfeeding support. I said some of our counties in Kenya, they are vast, and therefore even health workers making, reaching to those hard-reach areas become very difficult. And so that also is an ethical concern in terms of equity of services. The other one is on breastfeeding and HIV. We know that we recommend exclusive breastfeeding for even for HIV positive mothers, but of course the stigma, the family, some of the taboos, because you're HIV positive, you can't breastfeed. How do we, those ethical concerns, how do we ensure that we have empowered HIV positive mothers to make informed decisions when it comes to breastfeeding? On human milk banking, of course, the one we have at Pumwani, one of the key things we do is consent from the donors, informed consent. So at times also, there are ethics around it. The other one is also, some people really say, I cannot give my infant somebody else's milk. So those are issues, ethical issues that we need to look at even when we are looking at the challenges. So how are we addressing these challenges? Scaling up the baby-friendly initiative. I mentioned the two at the hospital level and at the community level. And of course, strengthening enforcement of the existing legal provisions that we have. That is the workplace policy, the Breast Milk Substitute Act, and other various acts. Then promoting culturally sensitive breastfeeding, scaling up workplace support, and also mitigating socioeconomic barriers through social safety net. For that one, we are having an integrated project, nutrition improvement through cash transfer, which is providing nutrition-sensitive cash for households with children under 3 and lactating mothers, giving them nutrition education. That's around mitigating socioeconomic. Then targeted support for pregnant and lactating women in emergency circumstances. I had mentioned what we give in terms of nutrition commodity, and also robust informed consent process, and addressing misinformation and commercial influence, especially when it comes to breast milk substitutes. So that's what I wanted to share with you, and thanks so much for listening.
Thank you very much, Ms. Kirogo, for highlighting these interventions. And in this conference, we are talking about that we need more resources. And one of the things she talked about, breastfeeding is a high impact intervention. Is a high impact intervention that I don't know how much we are promoting it. Dr. Kalimba, as a pediatrician, has also spoken about it. She has talked about women in prisons. I don't know whether you ever thought about that. She has talked about what actually Dr. Githinji highlighted this morning, digital AI. We are now at a space whereby we can actually, AI can talk about breastfeeding in the wrong way, and the next generation believes, or the current generations. So colleagues, we really need to remember that this is a high impact intervention that is in our hands. I want to usher us into the next part of our workshop. As I said at the start of this session is titled Breastfeeding Interventions, Navigating Ethical Challenges to Ensure Equity Using the Public Health Ethics Framework. So I want to introduce the Public Health Ethics Framework. So we are going to listen to a video from Professor Nicola from the University of Zurich. Professor Nicola is, for those of us who joined us late, she is the director of the Institute of Biomedical Ethics and History of Medicine.
Dear colleagues, I'm delighted to provide a brief intro to this session on the Public Health Ethics Framework. My name is Nicola Billa-Andorno. I am a professor of biomedical ethics at the University of Zurich in Switzerland, and together with my team, I created the Public Health Ethics Framework that is freely available on LactaHub. Needless to say, I would have liked to be with you in person for this important meeting. The timing made it impossible for me, but I wish you all a wonderful event with lots of interesting personal encounters and lively discussions. In the following session, you will, under the expert guidance of Dr. Alice Lakati and Professor Stephen Muhudia of Amref International University, explore the ethical issues of breastfeeding interventions. What I would like to do is help set the scene by briefly introducing the Public Health Ethics Framework as a key component of EFBRI. EFBRI stands for Evolving Ethical Framework Informing Breastfeeding Research and Interventions. Our aim was to create a central resource that would bring together the most important ethical issues of activities in the area of breastfeeding and lactation. We started out by first producing a volume on the ethics of breastfeeding research and then followed up with a second part on breastfeeding interventions, the Public Health Ethics Framework. It is this second part, we call it EFBRI 2, that you will focus on today. EFBRI 2 is a globally applicable ethics framework focused on breastfeeding and lactation interventions. It can help answer questions such as, how can we ethically design and distribute educational material on the importance of breastfeeding for maternal and infant health? What ethical issues do we need to consider when setting up peer counseling, for instance, for pregnant women with HIV, or home visit programs by breastfeeding and lactation consultants? The principles we laid out in EFBRI are not new, but the framework is new in bringing all those principles that are relevant to the ethics of breastfeeding interventions together in one place. The framework is based on existing international guidance, such as the Universal Declaration of Human Rights, and on a review of the ethics literature on the topic. We also presented EFBRI to different experts in the field and invited them to comment so we could improve the text. This is why we call the framework an evolving framework. It is a living document in the sense that it needs to be owned and improved by those working in the field in different settings around the world. EFBRI is not a legal document. It's not carved in stone, but reflects a process involving all those who are interested in contributing to protecting and promoting women's and infants' health and rights. Thank you very much for your interest.
Yeah, thank you very much. And we have heard a lot about breastfeeding, and now we want to address the issue of ethics, and we'll have some slides. I'll be using some slides which will help us in the discussion. But let us start by asking ourselves, what is ethics? Just briefly, I looked at the answers to your mentee, and we got many of them. We say that we are concerned with ethics, you are concerned about rights, you're concerned about what is doing things right, doing the things right, behavior, values, we had culture there was integrity, there were all the words that are relevant in the field of ethics. But ethics is about, let's have the next slide, the first one, yes. The ethics is about reflecting about what is good or what is bad from a moral perspective. And ethics, you could say, is also standards of behavior, standards of acceptable behavior within certain groups. Now, we have been told from the various speakers about breast milk, and we all have agreed, and there is lots of evidence that breastfeeding is good. It's good for the mother, it's good for the child, it's good for the community. So there we have agreed about it. So what is it about ethics that we still need to discuss about breastfeeding when it is a good that is for the, as we said, for the individual as well as for the public? So we say we then need to look at public health ethics. And in public health ethics, the goals are several. One of the goals is that there should be benefit to the individual and benefit to the community, that we should not do any harm in respect to what we are doing. So this good thing that is breastfeeding, how can we have the programs that we have outlined here, and my colleagues have outlined several programs which we are involved in, how can we do them, implement them, so that the good is received without doing any harm? It's also that there should be equity, that there should be that we should take aspects of justice so that there is fair distribution of the burdens as well as the benefits. There are benefits, yes, but certain people bear the burden. The mother bears the burden of actually taking care of the baby, providing the milk, and having to fit in with the other aspects of her work. We have also the aspects of respecting choice. And that is important because we are dealing with a person that has choices, and in many of our constitutions, and Professor Nicola has related to this, that there is issues of human rights in it. So we need to be able to do our programs inside, or rather, the goals of public health need to respect the autonomy, the freedom of choice of those that are involved in these programs. We, as has been said, we also need to be sensitive to the socio-cultural context in which we operate. Now, why is breastfeeding? Why are there ethical issues in breastfeeding? The most important thing is that breastfeeding involves, or is embodied in persons. It is about a person, and that person is a woman. It's about a person's property. It's about the woman's property, her breast milk. The breast milk that we are being told about is produced by that mother. It is her property, and yet we are coming in to say how to utilize it. That breastfeeding is about a child, and that is the woman's child. So we are talking about a woman, her body, her product, her child. So when you bring in product, you need to have that into context. And when it touches those three aspects, then ethics comes in. We are talking about a child, the interest of the child's health, the child's life. We are talking about, it involves the child's father, it involves the community, and it involves people who have to undertake these programs. That is the healthcare professional. Next slide. So the ethics framework, it comes in two parts, as Professor Nicola has said. The first part, which we are not dealing with today, addresses research in breastfeeding research, ethics in breastfeeding research. Part two, which we are dealing with now, addresses implementation programs, how to ensure that we comply by the ethical consideration, ethical requirements in our breastfeeding programs. Next one. So the framework, the EFBRI framework, is a collection of principles and guidelines, and there are mainly 9 principles that are covered by this particular framework, and it consists of it addresses informed consent, because, as we said, it involves the mother, a woman, her body, her child, her product. So in implementing the breastfeeding programs, we need to be able to be respectful of their choices, in that whatever we do, it should be voluntary. They talk about it addresses vulnerability, and Dr. Osman discussed that very well. I'll not go much into that. It talks about social and cultural contexts. It addresses social and cultural contexts in which we do the implementation, that we need to respect the cultures, we need to have community engagement so that we implement our our programs in a way that will respect culture. Next slide, please. The framework also addresses responsibility and accountability. And as we have one of the speakers mentioned, that we need to be responsible and we need to be accountable, particularly that those programs which we want to implement, that we should have evidence, scientific evidence, or evidence that they're effective before we bring them to our communities. Remember that we are dealing with very sensitive matters. We may be dealing with vulnerable communities. So it is our imperative as healthcare professionals that we ensure that the programs, first of all, we are convinced that there is evidence that they will be beneficial to our communities. So when you are translating a program from another community, do seek evidence that it is appropriate for your community. We also talk about risk minimization. And in some of these programs, there is risk. As we say, the risk may be physical to the mother, to the child, but it may also be psychological or social. It may also be economic. It may be emotional. It may be social in that it may, the main risk may be stigma, as has been said. Now, the last three areas that he talks about are incentives. That is that in our programs, we should not use undue incentives in order to get our programs going. And also those incentives which may interfere with the free choice, with the free decisions of the participants in our programs. We have, it was mentioned about conflict of interest. I think it's Veronica who dwelt on this about the conflict of interest. Now, we have talked about the conflicts of manufacturers of breastfeeding or nutritional products that may compete with breastfeeding. But there is another conflict of interest which is within the healthcare professionals that are implementing these programs. As healthcare professionals, we also have interest in whoever is our sponsors, whoever is our employers, that may make us use methods within the implementation which may be coercive, which may actually cause harm to the public, because we are so interested in taking back good statistics to our donors, our sponsors, or our governments, that you are not sensitive to the ethical issues that are involved in the program that you're implementing. We also talk about the post intervention access to the benefits or to what the program was assessing. A number of programs which you may have the baby-friendly hospital initiative or baby-friendly community initiatives. And it is sponsored for 2 years, and then after 2 years, the program has ended, and the community is left without ongoing access to the benefits of that particular program. So we need to ensure that. Now, a number of breastfeeding implementation programs have been mentioned, and I will not go deeply on them. They were clearly articulated by my colleagues. And I would just like to summarize by saying, next slide, that that ethical considerations are important because in order to preserve the dignity or to respect the dignity of the participants in our programs. And that is mainly the mothers and the children, but all the others who are associated with it, including the fathers and including members of the community. It should lead to benefit, and we should avoid harm, and we should also ensure that there is equity and that there is a fair distribution of burdens and benefits. And we should always have in mind community considerations. We should always have in mind community considerations, in that in thinking about the implementation, we should also know that we are dealing with it within the community and respect that community's socio-cultural beliefs. I think I'll stop there.
Thank you very much, panelists. Thank you very much, delegates. Without you, this discussion would not have been successful. Just the things that have come out from this discussion, quite many. I just want to summarize. We note that breastfeeding undoubtedly is the best option, is actually the best source of nutrition. We have also seen that the rates are increasing, but we can also see that there are threats. And while we are talking about technology, AI as a solution, we have also seen that technology can also be a threat because of the quick in terms of the information can move really fast. One thing I really want us to remember is breastfeeding is a high impact intervention. It is one of the most cost-effective, high-impact intervention that we should be talking about. And therefore, if it is a high-impact intervention, there is no reason why we should not invest on human milk banks, because it is already demonstrated is a high-impact intervention. So it's easy for us, I think, investors in the rooms, promoters of primary healthcare. If you really promote primary healthcare, this is an intervention that is really the backbone of primary healthcare. One thing that has also come out from this are the ethical issues around breastfeeding. I think we tend to simplify it, but we have been taught that there are ethical issues around breastfeeding. The whole process of breastfeeding interventions is about a woman, it's about her right, it's about her body. It's about even whether we see her as productive when the time she's breastfeeding. How do we elevate that component so that we don't see breastfeeding women as a cost to society? Like, I remember for me, my first job when I reported, my boss did not know that I was a woman. So yes, maybe he didn't read my name well. He just read the surname and assumed that I'm a man. So when I reported and said, oh, so it's a lady, I said, yes. And she said, no, I don't like women in here because they ask for maternity leave. Then they say the baby is sick, things like that. But that is like 20 years ago. So you can imagine that people don't see breastfeeding as a value addition to society. So I really want to thank all of us for coming to our session. I want to thank Amref International University with LactaHub for organizing this session. Take home, this is a high impact intervention. This is a primary healthcare intervention. This is an intervention that we should invest on if we are to achieve child survival. We are talking about lack of funding in this conference, but this is an intervention that can really save lives.